situation, you're gonna see it wherever you go in any residencies or any specialties you're gonna practice. So before we go, let's see. Let's agree on some of the terminologies. So we know that hematemesis is a red blood vomitus, and we know that some of the referring GI bleed to coffee ground emesis when it's look like coffee ground when they vomit, and also melena, which is a black tarry stool that it's really difficult to wipe and it's shiny like in the picture here. Also another terminology which is hematochezia, which is a fresh blood per rectum. We'll start with the upper GI bleed. So the causes for the upper GI bleed is multiple and many. The most common cause is peptic ulcer disease, and that's usually the common we see in our practice. So we'll talk about the risk factors for that in a minute, but this is the most common. And also the other one will be the gastritis and esophagitis. All of that can cause the GI bleed. But one of the other things that I would like to draw your attention is the esophageal varices, because that's one of the things that happen in patients who have a high portal hypertension or high portal pressures, which we'll talk about when we suspect that. But this is a nice picture showing you if you guys have a photogenic memories. So if you can start from here, that for causes of GI bleed is like varices, esophagitis or esophageal ulcer or medullary wise tear, which usually happen when patients have extensive retching. Then after that, they're telling you that we're vomiting clears. Then after multiple vomits, we have fresh blood coming, and this is a typical histories of medullary wise tear. The other things, as I mentioned before, peptic ulcer disease or gastritis or esophageal or stomach cancers and other causes. Vascular malformations, which we call it AVNs, or sometimes we call it GAVE, which is a watermelon stomach, also can cause GI bleed. Also, if the patient have a graft and the things in the duodenum, which is duodenitis, ulcers. The other things is rare to see, but it's scary when you see it, as when you have aortic grafts, and this is sometimes eroded to the duodenum and causing aortoduodenal fistulas, and they usually have significant bleeds. So back to the peptic ulcer disease as a common cause. We have multiple causes for it, or at least risk factors for it, which is H. pylori, as everybody know. Aspirin and NSAIDs also can increase risk for peptic ulcer disease, and if we combine the NSAIDs with also H. pylori, it's enhancing the risk for the peptic ulcer disease. Of course, SSRIs have some role in increasing risk for peptic ulcer disease. Other causes for that also enhance the risk is also, or other causes for ulcers is stress ulcers and Zwinger-Ellison syndromes. Now, by going to esophageal varices, which is, or gastroesophageal varices, which is, as I mentioned before, that when you have elevation in the portal pressures, either related to cirrhosis from significant resistance for flows inside the livers, or if they have an idiopathic portal hypertension of unclear etiology, sometimes they can go and cause a backflow of the pressures to these collaterals, and they cause gastric varices and also esophageal varices. So when we suspect that, as I mentioned, if we have a severe liver etiology, if the patient have a chronic liver disease, or patient is taking alcohol for a long time and excessively, because they can increase the pressures. Also, if they have a history of previous varices, and of course, if you see any signs of chronic liver disease, including ascites, jaundice, or others. In the labs, is if you see any changes in the coagulopathies or hypoalbuminemia, and also high bilirubins and thrombocytopenia, all that can hint you to that the patient might have liver etiology causing this bleed. How usually they present upper GI bleed? Of course, sometimes they might vomit blood, and sometimes they don't vomit. They only have coffee ground emesis, and sometimes they don't vomit. They only have melena, which is, as I mentioned, black tabby stool. All of that can present. Also, sometimes upper GI bleed, if it's a very massive GI bleed, then they might have hematochezia as a fresh blood, and usually these patients is hemodynamically unstable at that time because there is no time to digest blood to make it black, and that's why you see this massive GI bleed. Lightheadedness and syncope, also it can be a presentation. Of course, complications from this things can happen, like shock, aspirations because they vomited blood, or ischemia because they're losing a lot of blood during the GI bleeds. So most of it they spontaneously resolve, but sometimes we need to do an intervention for these kind of upper GI bleeds. So this is a case discussions. This usually I do it when we have a regular lecture, not in the virtual. So usually I would read it for you guys. As a 65-year-old female presented to the ER with vomiting blood over the last 3 hours. I usually ask, what do you want to ask and what do you want to know more? Usually what we need to know is the amount of bleeding. So how much is that? What's the nature of what you're talking about? Is it like fresh blood or is it coffee ground? Also, do you see melena or do you see hematochezia? Also, if they have any other symptoms with it, for example, any kind of pain, abdominal or chest, if they have signs of anemia, like shortness of breath, dizziness, or loss of consciousness. As I mentioned, sometimes they might have a history of retching or vomitings, then they turn to be blood, then this is, as I mentioned, medullary wax tear. Of course, weight loss and dysphagia is an important to be asked of because that can hint you to the etiology of the disease. Medication is important to know because, as I mentioned, NSAID, aspirin, all of that increase risk for peptic ulcer disease. Of course, you want to know if your patient is an anticoagulation or any blood thinners, antiplatelets, or if they are taking SSRIs, because SSRIs play in the platelets also. It gives some platelet dysfunction to some extent, so that's why they're asking if that. And also SSRIs can induce risk of peptic ulcer disease, as we just mentioned. It's important to ask about the past medical history, if they have the similar bleeding before, if they have ulcers before, or if they have any liver disease, renal diseases, or heart disease. Because, for example, if they have end-stage renal disease, they usually tend to develop vascular malformations and they might have a chronic bleed. So it gives you a hint of what you're dealing with. If the patient have any previous endoscopies or surgery, because sometimes anastomosis from surgery is bleeding, so maybe years after. So that's an important to ask. The other things is we go after that for an examinations. We start with the vitals. Of course, they can be normal vitals if they have like mild or minimal loss. And it can extend to shock. For example, hypotension, tachycardia, or it can be in the middle like a borsal drop or orthostatic hypotension. It's important to do the orthostatics because it gives you the hint of how much patient blood loss. Of course, in the examination, you should look for any stigmata of chronic liver diseases. And also you do a full abdominal examination. And one of the important things is really is a rectal examination because it can help you in terms of the patient is having bleeding, what kind, if you see fresh blood, because sometimes they give you a false informations. Also, if you can see if there is any local cause causing the bleeding, or maybe also you can see if the patient have a brown stool at that time. So it's really important to do it in any patient. Hit the ER with a GI bleed, he needs the rectal examinations. It's a crucial. And when you call any gastroenterologist, they're going to ask what the rectal exam is. For the NG lavage, it's been used in the past. It's still some people, they use it. What they do is they put in nasogastric tubes when the patient come, and what they do is they put some water inside the stomach and try to suck all the contents from the stomach and see if there is any bleeding happening there or not. This can help you sometimes, but you need to remember that if it's negative, there is a chance of 15% that you might miss blood, especially from the duodenum, because the blood is irritant, and when it's come refluxing from the duodenum to the pylorus will be contracting, so you might not see any blood coming because it will be blocked by the pylorus to come back to the stomach. So there is a chance you might lose it. If it's positive, it's positive. But if it's negative, there's still a chance of 15% that you may miss upper GI bleed. So this is what I just mentioned about the hemodynamic status. It's important to know when you have if you have a hypotension or shock, this means that more than 20% of blood losses happened, and which considered as a massive. Orthostatic, as I mentioned, is important to know because this has give you the hint if you're dealing with moderate blood loss, which is 10 to 20. If it's normal 5, does it mean that your loss is less than 10%? So how we know upper versus lower? It's history and clinical examination help you a lot to gather all information to help you to support your theories if it's upper or lower. But we classify upper versus lower is based on the ligament of Treitz. Anything below the ligament of Treitz, we consider it lower. If it's above ligament of Treitz, it's upper GI bleed. So how we know? For example, if the patient is vomiting blood or vomiting common ground, we know this is upper bleeding. If the patient has melena, it's most likely the patient have upper GI bleed. If they have fresh blood, most likely from the rectum, it's a lower GI bleed. Unless if they are unstable, there is a chance that you might deal with upper GI bleed. As I mentioned, that sometimes they might have an extensive upper GI bleed that the bowel is not able to digest it, and that's why it's come as a fresh blood. NG tubes, we talk about that might sometimes help. The other things is people like, even in the examinations, is the urea to creatinine ratio. So if it's more than 36, it's really giving you a hint that you're dealing with upper GI bleed, and they usually put that in the examinations or in the exams. So what do you do as a diagnostic evaluation for these patients? Of course, we do the type screens, we send for labs, CBC, coagulation, liver function test, of course urea and creatinine, because we want to see if the ratio is above 36, that can hint you to upper GI bleed too. Also, we send for cardiac enzymes and serial AKGs. So for the CBC, I will show you the hints that sometimes it's really giving you a false alarm. So when you do the CBC before the bleeding, for example, this is the RBC volume, this is the plasma volumes, and the percentage is the hematocrit, which is 45%. This is before bleeding. Immediately after bleeding, the patient, what he will lose the plasma volume and he will lose RBC volumes. So when they lose both of them, so the percentage is still, the hematocrit will be the same, 45%. It will not change immediately. So it's need time to recalibrate, like 24 hours, sometimes up to 72 hours. So it can show you the exact hemoglobin. So sometimes the message here is CBC sometimes can fool you. It might need time to show you that he dropped his blood or dropped his hemoglobins. Because if you see after 24 hours or to 72 hours, the plasma volume picked up again to its normal range, but the RBC, as you know, it's needed process to try to catch up the same and try to normalize later on using the iron, using the storage and all of that, so to can produce it. So the message is, don't be fooled by the CBC in initial presentation. It might not showing you the actual drop when they present. So what we do when they come in the emergency rooms, first, of course, ABC, we connect them to the oxygen, we connect them to cardiac rhythms and C and urine outputs. The other things point in the exam they like it is to make sure that your patient have 2 large bore IV lines, 18 gauge or larger. So it's a very important information is to make sure your patient have 2 big lines, so we can, if something happened, that we can resuscitate really quick. Also, we send the blood work, as we just mentioned, and we do gastroclobite, as we mentioned, sometimes, not always. Or we start him fluids if needed, and also we transfuse him blood if his hemoglobin is less than 7. In active cardiac patients, we target around 10 hemoglobin. We correct the coagulopathies and also the platelets if needed, so to help make the platelet aggregate very well. And also, we triage the patients. Should we send them to the floor or ICU? For example, if the patient has orthostatic or hemodynamic instability, no way you're going to send them to the floor. You need to be in the ICUs. And of course, you call the GI for consults. Mortality from peptic ulcer disease is sometimes reaching up to 10%, but usually around 5%. Our goal in the management is to stabilize the patient, figure out the source, stop the bleed, and treat the underlying abnormality and prevent it from happening again. So this is a picture just to show you what I just mentioned. The other things is we forget to mention is about the treatments for upper GI bleed is to give some therapy, which is a PPI, which is immediate when the patient arrives. And we give octreotide and antibiotics if we think the patient is cirrhotic or we have a hint of esophageal varices we're dealing with. So back again, ABCs, connect them to the monitors, prepare the labs, type and cross, do the medical therapy, call the GI, triage them to the ICUs or not, and then call GI for the endoscopy. But before endoscopy, things that can help the GI in terms of and help the patients is some of the things we do before the endoscopy. For example, we mentioned the PPI. PPI is really important to start as soon as possible. Why is that? Is to help in healing the ulcer really quick. So it means that when we go and do endoscopy, it's reduce our intervention to that ulcers because the patient starts healing up by himself. The other things is we would like to be given before the procedure, especially if they have upper GI bleed, is erythromycin or metoclopramide. This should be given like 30 minutes to an hour before we do the endoscopy. What's the yield of this? It's help us when we go to the stomach, we don't see a lot of blood. So because when you give erythromycin, it will make the stomach contract really quick and might clean the blood from the stomach and the early duodenum. So that will help us to reduce coming back with another endoscopy because we see a lot of blood. When you see a lot of bloods in the stomach, we cannot sometimes, or suction, it might work, but because of the clotting, we might not able to clean up all the stomach, which indicates when we say, okay, we'll bring him back and the next day, maybe after he clean up his stomach by himself, and to look up. So erythromycin is important to reduce the going for repeating endoscopies. So these medication, we make sure that patients have it when they have a GI bleed, upper GI bleed. When we do the endoscopies, usually within 24 hours following the resuscitative effort. Sometimes high-risk patients, we might expedite them a little bit, but not like within 12 to 24 hours. There is a studies recently been published this year that if we try to do it earlier than 6 hours, and they said less than 6 hours is increased mortalities for the patients. So what we do now is between 6 and 24 hours is all the endoscopy should be done within that time for the upper GI bleed. Then the other things is risk stratification, so it helps us to predict mortalities. There is a Rocal scores, there is a Blatchford scores, and there is a AIM65, which is a very simple score that a lot of resident students like it, which is the albumin less than 3, INR greater than 1.5, ultramental status, and also systolic blood pressure less than 90, and age older than 65. This is giving you a risk, predicted severity, and mortality for these patients. So how about, does rebleeding can happen? Yes, of course, rebleeding can happen. But what the factors associated with rebleeding? So if the patient initial presentation was hemodynamically unstable or hemoglobin less than 10, or if they have active bleeding during endoscopy, or if they have a large ulcer more than a centimeter, or if the ulcer locations is in a difficult position to treat by endoscopist, for example, posterior duodenal bulb or high lesser curvature. So all these things can factor into increased risk of rebleedings. So how we know that still the patient is bleeding or continue to bleed? So this is again with the histories and the clinical. So if the patient telling you still he's vomiting fresh blood, then again he might. Melena also, it can be a hint, but you need to know that melena can stay up to 7 days after treatment because it's still the bowels is cleaning up all the blood that happened before. So how we know that it's increasing? So if I have melanosis frequency, if the patient have one time, he's saying now it's become 1 times and it's keep cleaning up, it's become more brighter, it's mean that the stool become more brownish, and we'll be fine. But if he's telling you that, you know, no, my melanosis right now, my black stools has become more frequent, they have 3-4 times instead of 1 times, and sometimes I see blood with it, so it's mean that still he's actively bleeding. The other things is, of course, the vitals, like heart rate. Also, if you have connected to the central line, you can measure the central venous pressures, and if you see drop in the fecal, it means that his volume is down. Also, the urine output can give you indicator that he's losing volumes. NG tubes, as I mentioned, it's technicality, you might use it to see if the patient have an NG tube. You can try to suction and see if there is any fresh blood that's coming. Of course, hemoglobin is the one of the last things I will look at. As I mentioned before, it's react slowly to the events. So what's the role of endoscopy? Of course, diagnosis and prognosis. It helps you to predict what's going on, and also for endoscopic therapy. For example, let's show you here. For example, this is a clean base ulcer. So if we do not do anything, the risk of rebleeding from this is 5%. Here is a flat spot or pigmented spot. So if we did not do anything, the risk of rebleeding is 10%. So that's why in these two, we don't do any interventions. Here, there is a clot. This is where we have a debate. Either to remove it and see if you're dealing with this and we don't do anything about it, or sometimes, and sometimes what you see is you remove it and you find visible vessels. Here, if you do not do any treatment, there is a risk of around 45% of bleeding by itself. Oozing from that, the risk of rebleeding is 55%. And of course, if you have these spurting vessels here, if you see it, it's risk of rebleeding. If you don't do anything, it's 100% or 90 to 100%. So important because that's why in these three, because of risk of rebleeding is high, we treat these three, and we'll talk about the treatments. So, which was endoscopic with the oral or IV PPIs. For example, for flat spot and clean base ulcers that we just mentioned, we don't do any endoscopic therapy. Patient should be in oral PPIs, and if he is healthy, he can be discharged. If it's adherent clots, we might remove it depending on what we're dealing with, but he will need the IV PPI at least for the next 3 days. Like a patient who's having active bleeding or non-bleeding visible vessels, as we just show you, these patients need endoscopic therapy and 3 days of IV PPI bolus plus infusion. So when we do endoscopic therapy, we do endoscopic therapy in a patient who have spurting, oozing, visible vessels, and sometimes with adherent clot if we remove it and see what's behind it. We don't do any endoscopic therapy in patients who have a clean base or flat pigmented spots. So how about if the patient rebleed, should we go for endoscopy again or not? This is a study in New England Journal of Medicine. They randomized the patient between going for another look for endoscopy versus doing surgery for after the second time bleed. So they found that with the endoscopy, they reach 75% of hemostasis of the cases, and they have less complications. So now our recommendation, if the patient bleed again for the second time, then we go for endoscopic therapy. But if he bleeds for the third time, then no, this time we need to refer him to either interventional radiology or surgery. How about the time of staying in the hospital? As I mentioned, it depends on the stigmata when we see the endoscopy. If it's clean base ulcers or if they have a pigmented spot, then and the patient healthy, hemodynamically good, then he can be going home with the oral PPI. If the patient is having high risk stigmata, he needs at least to stay in the hospital for 3 days with the IV, PPIs, and monitoring. So this is, I will show you, this is the pictures of how we prevent bleeding from happening again. So we need to know the cause for this ulcers or this bleeding. So if it's H. pylori causing this ulcers, then we treat the H. pyloris. After we document the cure, then we stop the PPI. If the patient taking NSAIDs, then we recommend to stop NSAIDs, or if they require it for long term, then we need to add PPI and try to use selective COX-2 inhibitors. If the patient in aspirin, usually we stop the aspirin before if they come with a bleed, we can stop it up to 7 days, but after 7 days we need to decide. If it's for primary prevention, then we should not resume it. If it's for secondary prevention, then within 7 days we should resume the medication and also add PPIs. If we do not know the etiology of the ulcers, then we should maintain the patient in minimal dose of PPI long life until we figure out the cause. How about second look for endoscopy? Should we do any patients like after a few weeks to look in any patient? No, we only do it if the patient have gastric ulcers. We need to repeat it in the gastric ulcer to confirm. Usually we repeat it 8 to, I would say they're saying 6 to 8, but now we're saying 8 to 12 weeks. We repeat it to document healing of the ulcers, because sometimes the ulcer will not heal because it's cancerous ulcer. So we might need to take a biopsy when we go the second time to look to from these ulcers to make sure there's no cancer. So how about angiography or the role of that? So we don't use it that often in GI bleed. We use it if the patient is having persistent bleed that cannot be controlled by endoscopy, or the patient is hemodynamic unstable, then we send them for interventional radiologist. What they will do is they're going to try to inject contrast in the blood vessels and try to see the mapping and see if there is any extravasations and try to embolize it embolize it to help to control the bleedings. This procedures look like fancy, but have also some risk. Sometimes, of course, because you're embolizing something, it means that you're inducing ischemia, and sometimes it's might cause perforations and abscess from these interventions. The other things is other modality is a surgery, but it will be only for uncontrolled bleeding that us as a gastroenterologist and an interventional radiologist could not control. Either patient can go for ligation of the gastroduodenal artery, or they go for gastrectomy. So this is a pictures of, you can see here, this is a Mallory-Weiss tear, and this is in the stomach. The scope is retroflexing, and you can see this is a very bad looking ulcers, which look like cancerous ulcer. which need they take a biopsy from that. This is a clean base ulcer near the pylorus, and you can see it's a very nice clean, so this patient can be discharged if they are healthy. Here is look like, as you see, esophageal varices with red wale signs, which is concern for recent bleed, and this patient should go for banding. Now I'm going to talk about lower GI bleed. We know about lower GI bleed, as I just mentioned, is distal to ligament of Treitz. 90% of this bleeding stops spontaneously. Mortality is less than 5%. They can present with hemorrhagic shock sometimes, although it's rare, but it can happen. Usually our effort is to resuscitate them and prepare them for colonoscopies. 60% of them require therapeutic interventions. 40% is endoscopic hemostasis achieved, and some of them with IR has been controlled. 10% they controlled by the IR, and 25% they might need surgical intervention. The etiology for, which is important to know, is the etiology for lower GI bleeding. The most common is diverticulosis with a 30%. Then the colorectal polyps and cancers is the next, and the third is the anorectal fissure and hemorrhoid. Of course, ischemic colitis, angiodysplasia, which is vascular malformations, colitis, all of that can cause lower GI bleeds. Of course, to try to figure out what's causing it, the history is the key, as we just mentioned. We should ask about the quantity, the nature of the bleed that we're dealing with, and also abdominal, if the patient have any abdominal pain, tenderness, or if they have any anal pain or with a defecation or tenesmus, or if they have any altered bowel habits. Of course, you look for signs of shock like dizziness, collapse, all of that, or if they have any history of GI bleed, as we mentioned before. The past medical brag and family histories is important, as we mentioned in the upper GI bleed. Examination, we do the typical abdominal examination. Of course, general examination, you look to the vitals, you check the orthostatics. The important is the rectal exam, as we mentioned, to see the stool colors. You palpate for any masses, and also to assess for any hemorrhoids or prolapse or fissures. How the approach? The same what we did for the upper, ABCs, connect them to monitors, 2 large bores, cannulas, connect them to the oxygen, urine outputs, might need to give them fluids, blood, it depends on the hemoglobin levels. We correct the coagulopathies, we send for labs and cross-matching, and if we're dealing with the upper GI bleed or concern for upper GI bleed, then we might start them in PPIs and call GI for endoscopies. Also, we might, if there is a concern that maybe it's a very massive ACL bleed, also torsade antibiotics should be started. Surgery consult should be alerted. IR also should be alerted, because these lower GI bleed can really deteriorate really quick. And depend, sometimes we do if the hemodynamic instability and there is a concern for upper GI, we do upper GI endoscopies. And also we need to prepare patients for colonoscopy, which we'll talk about. So the basic components for the management is stabilization, localization of the bleed, and therapeutic intervention. To know exactly what the definition of the severe bleeding is, more than bleeding more than 24 hours, and if they need 2 units at least of bleeding or drop in hemoglobin more than 20%. So there is multiple independent predictor for severity of acute lower GI bleed. If you see, mostly it's a hemodynamic issues. For example, hypotension, tachypnea, syncopes, all of these three can be predictor for severity of the lower GI bleed. Aspirin use, non-tender abdomen, or if the patient have more than 2 comorbidities. If the patient have more than 3 of these, the risk of severe lower GI bleed is more than 84%. If they have 1 to 3, the risk of severe lower GI bleed is 43%. no risk factors is if they don't have risk factors, is the risk of severe lower GI bleed is 9%. So how we know the etiology, as I mentioned, we might need to do colonoscopy, but sometimes there's another modalities which is we call it tank scan or bleeding scan or nuclear scantographies. And also this might help us to identify where the bleeding is. The beauty about the nuclear scantography, it can detect you very minimal blood loss of up to 0.1 ml per minute, compared to the angiography, which they put a contrast that this might take you 1 ml per minute, so you can detect bleeding. So if the bleeding is less than 0.1, then the nuclear scan will not detect it, so will be puzzled. But if it's 0.1, which is very low, 0.1, it's very sensitive, so it will show you where is the location of the bleed at least. For the angiography, which is interventional radiology, you see here the leaks. It needs at least a GI bleed that's at least of the flow of around 0.5 to 1 ml per minute, so they can detect it. And when they can detect it, they can embolize it, and we talk about the side effects from these embolizations. CT angiograms is sometimes we do it as a prior step before we send them to interventional radiology. It's a little bit sensitive than interventional radiology. Interventional, I would say they're detecting 1 ml per minute. CT angio, they might get 0.5 ml per minute. So it's non-invasive compared to interventional radiology, which is a mesenteric angiography. This is more aggressive. This is and they have a therapeutic approach. But for CT angio, it's just to detect the problem. What is it exactly? Colonoscopies is one of the gold standards, and it have high diagnostic yield, up to 90%. And but the problem with it's need go likely preparation or colonoscopy preparation, which might take 12 to 24 hours. It can help in identifying lesion up to 75%. It reduces the hospital stays, and the complication from this procedure is negligible. This is how we approach lower GI bleed. It depends. If there is a suspicion for upper GI, then we do the upper. If there is no suspicion and patient show stabilities and minor bleed, then colonoscopy we can prepare the patients for colonoscopy within 24 hours and do it. If they have a massive lower GI bleeds, and depend if they are unstable, then they might need to call the interventional radiology and also the surgery to be back up if the interventional radiology could not stop it. Sometimes we do colonoscopies and upper endoscopies and we don't find the cause of this. Sometimes we go for, if that's all of negatives, and we might send them for, if they're still actively bleeding, we might send them for nuclear scan, or we send them for interventional radiology, or sometimes we do a capsule endoscopies if they are really stable and very minimal loss of blood. Then we might send them a capsule to look if there is any cause for the bleeding. This is some of the, we talk about the most common cause, which is the diverticulosis, which is the herniation. You can see here the buckets inside the colon. It's herniation of the mucosa and the submucosa through the muscularis wall. It's happened because of the pressures inside the colons. It's pushed these at the point of the entry of the small arteries. So that's why it's forming these pockets. Usually it doesn't cause any problems, but it's having a little bit higher risk of developing diverticulitis and diverticular bleed. So how about this diverticular bleeding? Is that common? In the Western world, yes, it's common. Here is less, but now with the trend of changing the diet, things has become different. We have become more like a Western countries. We're seeing it more in the with the elderly people. This seen in the younger people. Usually they have, and that's the key of the lower GI bleeds, trying to identify it. They usually have painless hematochezia. And usually this kind of bleed stops spontaneously more than 70% or 75%. The other cause is ischemic colitis. Ischemic colitis, usually the story is a patient who has a vascular bath issues, having heart disease, AFibs, having peripheral vascular disease, who presented with painful hematochezia. And this is kind of give you a hint that the patient might have ischemic colitis, and usually happen in the watershed area, which is between the inferior and superior mesenteric artery, which is this area, which is the splenic fractures. IBD, you can see here, this is the couple stonings pictures, and this is diffuse inflammation going with the UC, and this is with the Crohn's. This is the stomach colon cancer or polyps. You can see the polyps here. They remove it and they clipped it, and this is after this is the polyps was removed, and this is after resections. This is upper core, as you know, and this is a common things you guys know about. This is how it looks like in the colonoscopies. So you see this mass fungating or coming protruding to the abdomen. Angiodysplasia, which is arteriovenous malformations, you can see like that, and usually treated with algoplasma coagulations. Radiation proptitis is a form of vascular malformations. Usually happen in a patient. Usually, patients have chronic hematochezia, painless, and usually happen after radiations. For example, 8 months after radiations, and the treatment for these kind of things is mostly endoscopically by burning it like this one with the algoplasma coagulations. Thank you very much. I think that's it. Please let me know if you have any questions or consider I can address.
Thank you, doctor.
Any questions?
All clear, doctor. Thank you.
Thank you very much, and have a wonderful day. Bye.